Hello, everyone. Welcome to our special event today, organized by GC Labs, about public-private partnerships in global health, getting the best of both worlds in the testing space. Our event today is about the testing space, is about partnerships between two sectors that have been historically working separated. But in the last 2 decades, we have seen a big change, a big paradigm change in global health. Once government-centric, the testing sector was taken care by ministries and public entities. Today, we see much more a multi-stakeholder approach with the private sector and the NGO organizations being partners of the government. And it's a dialectic evolving process. The public sector is taking advantage of many of the features of the private sector, its dynamism, its innovative approach, the capacity of bringing different innovations to the patient. And also, the private sector is understanding and including much more objectives from the public health sector and incorporating them into their corporate identity and strategies. So these multi-sectorial alliances can result in very effective vehicles for solving very complex global health and public health matters. So today, we will share with our panelists some concrete experiences of partnerships between these two sectors, public and private. We will talk about some of the challenges, and we will try to think together how to get the best of these two worlds. We have a panel of 5 international specialists, starting by Professor Kazatchkine. Professor Kazatchkine has over 35 years of experience in global health as a physician, researcher, advocate, and diplomat. He attended medical school in Paris and completed postdoctoral fellowships in St. Mary's Hospital in London and Harvard Medical School. And he also holds a number of honorary degrees in the University of Brussels, University of Louvain, Geneva, etc. He's emeritus professor at the René Descartes University in Paris and has co-authored over 500 scientific publications. He has also played key roles in various organizations, director of the National Agency for Research on AIDS in France, executive director of the Global Fund to Fight AIDS, Tuberculosis, and Malaria. And Professor Kazatchkine is a special advisor of the WHO for Eastern Europe and Central Asia. Dr. Un-Yeong Go is the director of the Center for Infectious Diseases of GC Labs in Seoul. She is in charge of operational research and education program on infectious disease, including COVID-19, HIV, AIDS, and TB. Dr. Go is an infectious disease epidemiologist. She completed the medical school at Un-Yeong University and trained in preventive medicine at Seoul National University of Korea. In 1997, she joined the Korea Disease Control and Prevention Agency. She has worked for the World Health Organization in the Division of Pandemic and Epidemic Disease, and she has also served as TB program manager in Korea. And finally, she has been a board member in several international organizations, including UNITAID in Geneva. Dr. Saeed Al Rashdi is the chairman of microbiology department of the King Fahd Medical City in Riyadh, Saudi Arabia. And he's also the head of lab operations in the same medical center. He's the head of point-of-care testing in the King Fahd Medical City as well. He works as a transformation consultant with the MOH in the Ministry of Health of Saudi Arabia. He was graduated as Bachelor in Medical Science in the King Abdulaziz University in Saudi Arabia, And he obtained his master's degree from RMIT Australia and his PhD from Monash University in Australia. Professor Eskild Petersen from Denmark is a professor emeritus of infectious diseases, Faculty of Health Science, Aarhus University, Denmark. He chairs the European Society for Infectious Diseases Task Force in Basel, Switzerland. Dr. Petersen graduated from medical school at the University of Aarhus, Denmark, and holds several specialist degrees in the University of Liverpool, Copenhagen Business School, and Karolinska Institute of Stockholm, Sweden. He is the editor-in-chief of the International Journal of Infectious Diseases and has served as an editorial board member of the Expert Review of Anti-Infective Therapy. Professor Petersen has published over 330 papers in peer-reviewed journals. And then Dr. Hyun-Hee Lee is a clinical pathologist with over 30 years of experience in laboratory medicine. She graduated from Emwa Women's University School of Medicine and obtained her PhD in laboratory medicine in the same university. Her residency was at the Haljun University Hospital in South Korea in laboratory medicine. She received her MBA from the Yonsei University Business School and completed the Global Health Delivery Program by Harvard University. Then she has also graduated from the program of Artificial Intelligence and its implications for business strategy by the MIT Sloan School of Management. She joined GC Labs in 1990 and has been its president since 2007. So with that, let me brief you about this panel today. The panel will last more or less an hour. We will have 2 rounds of questions. We will be touching on different matters from different angles and experiences of the panelists. And let me start with Professor Kazatchkine. Let me move there. Let me start with Professor Kazatchkine and his views in a subject that is incredibly important. It's a pillar in the global health response. Why has large-scale testing been so critical in the fight against global pandemics?
Well, thank you. Thank you very much, Lelio. Does this work? Yeah, can you switch on the microphone? Okay. Is that better? Okay. Thank you very much, Lelio. And let me first thank also Dr. Lee and say that I'm truly pleased to be here with you today, also with my co-panelists. With the risk of stating the obvious, let me just answer your question to sort of frame the space of our debate. Why do you test? You test to confirm or to invalidate a diagnosis. And in our discussion today, the diagnosis of an infection. Mm-hmm. And why do you want to diagnose an infection? It is to bring both to the individual and to the collective, from a public health perspective, potential benefits. Mm-hmm. From the public health perspective, that benefit is, of course, understanding the epidemiology of the disease, understanding how it is transmitted, whether it is contagious or transmissible, understand the spread, the rate of spread of the disease, the modalities of spread, but of course then to guide the public health measures that we'll be taking. And COVID-19 is the obvious example where epidemiology guides public health measures at national, local, and international level. And of course, as you screen and test for epidemiological and public health purposes, you will also keep a number of samples to sequence and to be able to detect in real time the occurrence of new variants of concern. Now, from an individual perspective, the perspective for the individual may sometimes be fully convergent with that of the public health needs. Sometimes they may diverge. But from the obvious first answer to your question is you want to test because if you know you have an infection, you can access to treatment. And that's the obvious case for HIV, for tuberculosis, for hepatitis. And the literature now has, and the experience told us that the sooner you're diagnosed, the sooner you start the treatment, the better is the prognosis. So there's no issue there. When it comes to COVID-19, I don't know how it is about you in the audience, but I've heard many times, why should I test myself if there's no treatment anyway? And this is also something I had heard actually many years ago in the early days of HIV. That's not really true. I think you have to test yourself first because now, for people who are at high risk of evolving towards a severe form of the disease, people with comorbidities, people, senior people, and so on, we now have treatment. We now have monoclonal antibodies. We now will have soon some of the oral treatments that I'm sure everyone has heard about that will really help these people to be protected from severe disease. But then, testing also leads you to prevention behaviors. And those prevention behaviors cannot, for years and months, be imposed on you by the public health system or by the government. We have to learn to self-manage prevention and to self-manage our quarantines and to contribute ourselves to public health through responsible self-management. We've seen that, of course, in HIV. Again, I keep referring to that disease because you can't impose to people to use condoms. You have to inform people and have them responsibly use their prevention. And from the very early days in HIV, people from the community, patients, have been saying, I will be better able to manage my life if I actually know my status. So testing, fundamental. In COVID-19, what I find interesting is that from the early days in the emergencies, basically we were doing PCR or mass PCR testing, and now that we are moving to a different stage of disease, I don't want to call it endemic, but as we move to a different stage of disease, we understand the difference between diagnostic PCR and rapid tests for screening, and now more and more self-testing. And I believe that as we move further into that pandemic, we will partly delegate the public health responsibility from the government somehow and public health authorities to people so that they behave responsibly. And in my country, France, and in Switzerland, where I live, we're now overwhelmed with Omicron. It's 95+%, and it's just unmanageable to use the same screening techniques as we had a year and a half ago. So I'll stop there, saying that from what I've been discussing very briefly in these 2-3 minutes, the lesson learned to me is moving from, in an early phase of a pandemic, top-down public health indications of testing to progressively moving to decentralization and ultimately to self-management by the patients of their disease.
Thank you, Professor. And very important insights on the evolution of the testing space, moving towards a point-of-care approach and empowering the patient. South Korea has been an example and a leader in the response of several outbreaks, and especially the COVID one. In your role as an epidemiologist, Dr. Go, what would be your insights, having worked more than 20 years in the Korean CDC? How would you characterize the response and how it was managed in your country?
Thank you. Thank you very much, Dr. Kazatchkine and Mr. Lelio. Dr. Kazatchkine covered all the stage of COVID-19 pandemic from first stage and this latest Omicron stage. I would like to share my thoughts based on my experiences and working as an epidemiologist and public health officer at Korea CDC, mostly focusing on the early stage of COVID-19 pandemic, how Korea responded well in testing and tracing period, and would like to the background, how Korea responded so quickly in testing areas. We, as a public health officer, I experienced a 2000 influenza pandemic and the outbreak of Middle East respiratory syndrome MERS outbreak in 2015. During the 2000 influenza pandemic, antivirals and vaccines were available, so Korea was able to respond well. You may be wondering how Korea responded well to COVID-19 pandemic in early stage of epidemic in 2020. This can be easily understood if you understand what happened in Korea during the MERS outbreak. In 2015, Korea faced huge challenges due to MERS outbreak, and around 200 cases occurred, including 38 deaths. In 2 months from May to June, the case fatality rate was 20%. One of the key striking features of MERS outbreak is that 80% of transmission cases are caused by 5 super spreading events. At that time, the media broadcast new cases every day, and citizens were sensitive to outbreaks and investigations. Citizens learned that preventive measures such as wearing a mask are important to prevent infectious diseases. I would say that in 2015, during the MERS outbreak, the South Korean government and citizens have painfully witnessed and experienced how one missed case can trigger a huge, large-scale nationwide outbreak, and understood that probably aggressive quarantine may be necessary to stop the transmission of infection. Based on these lessons learned from MERS outbreak, when COVID-19 outbreak began in Korea in early 2020, the South Korean government quickly established a 3T strategy. This is testing, tracing, and treatment. It played a key role in containing COVID in the early stage of epidemic. Korea developed diagnostic kits very quickly and increased laboratory capability through the collaboration with commercial clinical laboratories. Dr. Lee Eun-hee will explain about it in more detail. Korea's response to COVID-19 has been grounded on the principles of openness, transparency, civil society engagement, and innovativeness. And Korean citizens have followed well the government's contact tracing measures and recommendations for public health measures, such as wearing a mask and social distancing. In conclusion, I would say that Korea adopted well the lessons learned from MERS outbreak. Thank you very much.
Thank you, Dr. Go. And what we can retain from here is the proactivity and the rigor in early tracing. And this proactivity, in the case of Korea, was a clear determinant of your success. Dr. Saeed, you have a unique experience in charge of the central lab in Saudi Arabia. That gives you a hands-on, very practical experience. What would be for you the highlights of your responsibilities today and some of the challenges?
Thank you. Thank you very much, and thank you for GC Lab to give this opportunity and to talk about our experience during this pandemic. This is like an unknown virus, unknown disease, and they don't have any treatment. As a professor said, it's huge screening was needed to prevent the community from the get infected and to protect also the health system from getting collapse from this unknown virus. And was the central lab is not ready to do this huge mass screening. It was only 22 regional lab across the country and small molecular biology in some hospitals, which was busy with doing some PCR testing for patients and blood bank needs. And when we start like a mass screening, we are capable to do it around 5,000 per day. And private participation was needed urgently to the prevent committee from this contagious virus. Therefore, like as one solution, do it is assigning contract with the BGI lab to bring some equipment and staff to do the training and helping in mass screening and allow the hospitals to do their routine job. And in 3 weeks, we increased the number of screening from 5,000 to 55,000. It's a huge increase and help a lot in this screening and did good protection for the health system in Saudi Arabia to not get collapsed, and only patient get their chance for the treated they needed from coronavirus or other diseases. And also is start to changing with this mutation from doing the screening and sequencing to the rapid testing. At the moment we are doing 72,000 rapid tests. Still, we already approved the self-assessment and you can do it, buy it from the pharmacy and do it. This was very helpful to protect community and the health system from collapsing and doing their own job. They do it. Yes, it's private participation and mass screening was very helpful. Decision Kingdom do it to protect their community from the get infected. Thank you.
Thank you. Thank you, Dr. Saeed, for these insights reflecting some of the challenges and the success. I would be interested in more detail on the financial side of your work. We know that Saudi Arabia has the means and the possibilities to support a robust response and a solid testing strategy, but how are you living this, and what are the challenges in that sense?
Mass screening is always cost a lot of money to the budget of the kingdom, but they are doing same compare between if the patient gets sick, system collapse, doing ICU, which is more costly from the screening, and they found that doing a huge screening is much better for them economically to reduce the cost of treat the patients and collapsing the system. Yes, it was very expensive, but if you go to the benefit, from financial perspective, it's spending a lot in the screening. Also, like reduce the cost of treating the people and cost of the ICU. I remember the number of ICU beds during the pandemic is increased by capacity by 200% for the actual, and now we got plenty of ICU beds, which is very helpful for the current patients from other diseases, not just from the coronavirus.